What's up, everyone? We're back. Dr. Maxfield, Dr. Shah. Welcome back to our channel, Dr. Lee, where we talk about all things skincare and dermatology. And today is our first episode of the Dr. Lee Dermatolympics. What is this? Today we're going to be playing a little bit of a game. I have downloaded some photos for Dr. Maxfield to look at. I'm going to quiz him on if he can get the correct diagnosis, but we want to play along with you. And I think this is going to be a good way to learn a little bit about dermatology, learn about what goes on in our minds. So we're going to be playing this game today as, is it acne, is it rosacea, or is it neither? And if it's neither, then what is it? Because not every red bump on the skin is acne, not every red bump on the skin is rosacea. So we want you to participate, go along with us, see if you can come up with the diagnosis.
I'm a little nervous because, what if I get one wrong? But I'm going to get one wrong invariably. I'm going to get one wrong at some point. So
that's actually really important to note in general, because if you see a dermatologist, they may not get it right at first. We look at thousands of these pictures during our residency training, and this is actually how we train. This is called a Kodachrome, and we basically show thousands of these pictures, we describe them, and after describing them, we try to come to the diagnosis, and people actually quiz us just like this, and this is how we learn along the way. But sometimes we're going to be wrong and we'll try a certain treatment, it won't work, and then we'll pivot the diagnosis, or we'll have to make a biopsy to make the correct diagnosis. But this is kind of what goes on in our mind when we're looking at a patient and we're looking at these photos.
From us, it's just like the more you know, the more educated you can be, the better decisions you can make, and then the more deliberate you can be with your skin and your skincare and how you approach it all.
First episode of the Dr. Lee Dermatolympics. Here we go.
Here we go.
All right, so first photo up here, is this acne, rosacea, or neither?
All right, I'm gonna kind of just verbalize my thoughts here. Actually, I'm gonna pause. We'll let you think about this. Maybe, I don't know, like 5 seconds, you can make up your mind.
That's enough time.
Okay, so, all right. So we take the whole patient into context here, right? So I'm just gonna start with, I guess, age. Patient seems to be older than perhaps 30 years old. I think that's a fair wager. And we see these red bumps throughout the face. Some of them have little heads of pus, so pustules, and then it's centered mostly over the nose, nasal tip, and then the cheeks, including the jaw as well. Notably, it actually spares the area immediately adjacent to the mouth. All of this taken together makes me think it's rosacea, acneiform rosacea.
So some people call this adult acne, some people call it rosacea. There's a whole different subsets of rosacea, but this is rosacea, which looks like acne, but is in the center of the face. Sometimes it's just redness, sometimes it's just dilated blood vessels, sometimes it's papules and pustules. This is rosacea, which we treat different than acne.
Yeah, they do, and there's some overlap, and we've talked about this in our acne videos and our rosacea videos, which our rosacea video was one of the best deep dives we ever did, but it was so low quality because we shot it so long ago.
We'll probably do a new rosacea video. All right, next photo. Is this acne, rosacea, or neither? And if it's neither, then what is it?
Okay, you get 3 seconds. Okay, time's up. So this patient appears to be younger. We have multiple flesh-colored and darker papules, which are just those little bumps spread out again over the central face, most prominently in the area immediately adjacent to the nose there. We also have a mustache. I'm gonna go with other here. And the reason is what? I don't see any pustules, which are those pus-filled bumps. I don't see any open comedones, which are kind of like blackheads. So I'm taking us to the other route, and this takes us to what we call a lumpy, bumpy face differential of kind of rare conditions.
Okay, so what do you think it is?
This, I'm gonna go with tuberous sclerosis.
Tuberous sclerosis, a genetic condition, mutations in tuberin or hamartin. Essentially, it leads this mTOR pathway to be upregulated. You produce these bumps on the face. You also produce other growths elsewhere in the body, but central face area, what we call angiofibromas that occur right in the central face here. They look like this. They're smooth. They're not acne, but they are little bumps on the face. You could have tuberous sclerosis.
You could, but I wouldn't leave this video thinking that you do.
Just kind of trying to expand your thought process on what little bumps could be. So tuberous sclerosis, genetic condition, many other things associated with it other than just bumps, but sometimes presents first as bumps on the skin.
I think a dermatologist's value in the real world, we see something like this. Actually, one of the first things that comes to mind is what else could be involved. So the little bumps on the face in this are actually inconsequential. All it means is it's a marker for something that could be more serious and significant going on. So that's kind of our role sometimes. We're just like, oh, I see a red flag. I've got to get you to the right people.
Then you're gonna look for other signs on the body, which you can get these like white spots on the body that occur with this condition. And then you'd worry about maybe getting an MRI to look for hamartoma growths inside the brain. So it's all kind of connected. Things to look for. One of the clues we look for in dermatology. Okay, next one.
All right, so again, a few seconds for you. I wonder if we're gonna end up cutting out these seconds. It's so hard to have dead space on social media. We're so not used to.
We could put like a game show sound.
So here we have what looks like a younger individual. Excellent hairline. Very fortunate. We have multiple small red bumps. It looks like they're in different stages. I might need to zoom in here, but it looks like we have little red. Oh, they're not. They're mostly little red bumps. Some of them are open comedones. Monomorphic is a word I would use here, where they all look very similar to one another. And then also the front of the chest was involved kind of pre-sternally. I don't see a lot of open comedones though, like the blackheads. So I'm gonna actually go with fungal acne here. Was that an option? Acne, rosacea, other?
That's other, yes.
So other, fungal acne is what I'm considering here.
Yeah. Fungal acne, properly known as pityrosporum folliculitis or Malassezia folliculitis, overgrowth of a yeast Malassezia inside the hair follicle, leads to these bumps on the skin. They all look the same, what we call monomorphic, not perfect in every patient. One of the things that will help clue you in when you're seeing this patient is, are these bumps itchy? Or are they more like painful and kind of drain pus? And so itchy, I always lean towards pityrosporum folliculitis, which is going to be treated with antifungals.
I know, I'm 3 for 3. I'm like going to be devastated when I fall short here, and it's invariable. I'm going to. And then someone in the comments will be like, I knew what that was.
All right, what is this? So, okay, so acne, rosacea, or other? Neither.
Okay, neither. So here,
this is neither?
No, I was telling him the other way to say neither.
Oh, neither?
No,
it's not neither.
He just doesn't have any friends from
neither.
England, that's all. Uncultured. So here we have another young individual. We have a lot of red scarring bumps on the chest. It extends up to the neck. And so we know this has been going on for a while. So acne, rosacea. Oh, this is acne, rosacea, neither. I'm gonna go with acne here. And whenever I see this kind of eruptive, highly inflammatory scarring form of cystic acne, especially on the trunk, I feel like it comes up on the trunk a lot, or at least often enough. I'm thinking like acne conglobata or acne fulminans here.
Right, so a severe form of acne can be associated with other things as well, but this is a really inflammatory type of acne. Now you'd say, well, can we just use our over-the-counter benzoyl peroxide washes on this or your topical retinoids? Not going to touch this thing. So what is the best treatment for something? Usually something systemic. You could use systemic antibiotics, but a lot of time you're going to use oral isotretinoin or Accutane if it is appropriate for the patient. Now the question here is, would you just start that alone? So this is another thought, like bad acne, okay, isotretinoin, easy answer. Well, maybe not, because this can actually flare really bad when you have what we call acne conglobata, and you may actually need to put them on steroids first so that they don't have like almost a severe form of purging with this type of acne.
So this, I mentioned in our most recent live, is just when we talk about acne purging, oftentimes we kind of think about it over the counter, like using over-the-counter retinols. Your acne gets worse after you start using. Is it purging? Is it not? This can happen to the extreme, and this is something we see not too infrequently, but people who have severe, highly inflammatory acne to begin with, when you start them on treatments, it could flare up to the point where they have systemic symptoms like fevers, chills, joint aches, bone aches, and then just severe scarring after that. And so you have to be very, very vigilant and aware that this can happen, because you either want to start them on steroids initially or concomitantly with Accutane or isotretinoin. So you blunt the inflammation that's underneath the skin surface at the same time you're treating the acne. So this is purging to the extreme.
And this type of acne is scarring. The scarring is permanent. And so this is the type of acne you do want to see a dermatologist, and you do want to seek out systemic therapies that you're going to take by mouth. So just keep that in mind. Not all acne is the same. Some is more severe than others. Next photo, do we have acne, rosacea, or neither?
Artie Sequeira, I'm putting a meme of you up. Okay, so here we have what looks like another younger individual. We have obviously highly inflammatory nodules and cysts occurring over the cheeks, the nose, even into the nose itself, and chin, and they get this like yellow honey color just crust over the top of it. It may just be pus in this case. I'm actually gonna go with rosacea here, and I'm gonna go with the sister of what we just talked about. I think this is like Rosacea fulminans. Maybe I'm wrong.
So he's correct. So this is Rosacea fulminans, also known as pyoderma faciale, which is a severe form similar to acne conglobata, a severe form of instead rosacea. Again, needs to be treated with systemic therapies. Very painful, very uncomfortable. We see this happen every now and then in the office, devastating for patients. And so definitely seek out treatment if you have this form of rosacea. You need to be on aggressive systemic therapies for this. Okay. Next photo. Is this acne, rosacea, or neither?
All right, so here we again have an older patient. I just go with older than 30 as our current mile marker. That's probably being generous. But
30? You think he's 30?
No, I think he's older than 30.
Oh.
Multiple maybe blackheads, we could call them blackheads, but they're open dilated comedones and cysts over the cheek, the nose. Interestingly here, actually periocularly on the eyelid skin and the thin periocular skin here. That's a really uncommon place to get true acne, by the way. Anytime I see something there, I'm like, what else could be going on?
Acne is a disease of the pilosebaceous unit or the hair follicle. To make it simple, there are no hair follicles on the eyelid. If you have something growing on the eyelid skin, it's going to be not acne most of the time.
So with that being said, this is neither. This is Favre-Racouchot syndrome and from chronic sun exposure.
So chronic sun exposure leads to these open comedones or blackheads in the skin. When you look at this underneath the microscope, you see these, but also you see a lot of damage to the surrounding elastic fibers and collagen, what we call solar elastosis underneath the microscope. Very, very damaged skin. If you don't protect your skin from the sun, you could end up Favre-Racouchot syndrome, ricochet syndrome, which is obviously you don't want that. So sun protection, very important beyond all the other things we always talk about.
Yeah, you don't really see a lot of this when we talk about sunscreen, but we see this in the real world. I mean, almost commonly. It's not rare.
Oh, all the time.
Yeah.
Especially where we are by the beach. So we see this all the time. It can happen and will happen
to you.
To you if you don't wear sunscreen. Next up, acne, rosacea, neither.
Okay, so we have a young individual once again, multiple little whitish papules and bumps here, again, around that ocular eyelids, eye skin. Now, my main consideration here is these things look, again, into the neither category. These look like milia to me. There are other things in this area that can mimic milia, and so I'm like suspicious already, but they do have a really strong whitish hue, especially that one underneath the eye, so I'm gonna go with milia. With that being said, what is the significance of having this many milia at a young age? It could be tremendous. So already that same like red flag in my mind went off like, okay, does this person have a rare condition? So I'm gonna say these are multiple milia, and then probably some condition involved as well.
Multiple milia, whether or not this is associated with another condition, which there are genetic conditions where you can get multiple milia, is unknown because this photo wasn't associated particularly with that, so we don't know necessarily the history. But good points here that we don't have the oil glands here, we don't have the hair follicles, so not likely to be acne. Could be rosacea or periorificial dermatitis if it was more red, but these are little white keratin balls that get stuck underneath the skin. Around the eyelids, we can get something else called syringomas that can look very similarly, but those are more sweat duct tumors, and these are more actual keratin balls stuck underneath the skin. Why this happens in young people, we do see this happening in young people. It could be because of their moisturizers. It could be the fact that when you're younger, your skin cells are stickier or what we call more cohesive, and so you're not able to expel the keratin as well as other people. So these are milia. These do either need to be extracted or maybe retinol or an exfoliant can help get rid of them, but we would just kind of pop these out with a little blade, squeeze them out. It's a lot of fun. We've done a video on it. We'll link it above. You can watch our milia video.
This person could keep you busy for a while.
Yeah, this would take like 30 minutes, but it would be a fun 30 minutes, I'll tell you that much. Next up, acne, rosacea, or neither.
This one's actually hard, I think, for a couple of reasons. So again, you're a patient, forehead. We have open comedones, those little open blackheads. I see a couple inflammatory pustules on the forehead too. So it's not truly as monomorphic as that first picture we saw. I would go with acne, but anytime I see acne on the forehead here, I consider like pomade acne in particular, just a
acne cosmetica, which is basically like occlusion of your pores from like your hair products.
Yeah, I'm gonna settle on acne in this one.
Okay, so this is comedonal with a little bit of inflammatory acne around it. Exactly correct. I think he's got 100% so far on this test. So this type of acne, right? So when we talk about acne, we showed some severe forms, acne conglobata. Now we're showing a more mild form of acne. Now this type of acne could respond very well to over-the-counter treatments like your Differin, adapalene, or your benzoyl peroxide or salicylic acid. I think it will do really, really well with these, as a matter of fact. This is the type of acne you may want to try some over-the-counter products first and then see your dermatologist, or just make sure you're getting the right diagnosis from your dermatologist. This could be exacerbated by your hair products, including your pores, or it could just be regular teenage acne that you would get. So thank you for participating in our first dermatology quiz bowl. I hope this video showed a little bit that Dr. Maxfield is pretty smart and got 100 on the test, but also to show you what goes in our minds when you come and you see us in the office.
Part of the value of seeing a dermatologist is they have experience with the breadth of treatments from over the counter to knowing when someone does actually need something prescription or stronger. It's important to have that input so that you can make what I would say like an educated and deliberate decision about what's best for your skin.
I will say, a lot of times it is the more common diagnosis. A lot of times it is your acne, it is your rosacea. But every now and then we have a patient that comes in and it just doesn't seem right, and we lean towards one of these other diagnoses. If you like videos like this, let us know. We can do more videos like this and kind of have fun with you all. So thank you all so much for tuning in.
Yeah, we greatly appreciate it.
Please like, comment, and subscribe, and we'll see you in the next video.
See you next time.
What's up, everyone? We're back. I'm Dr. Shaw. I think actually you go first. What's up, everyone?
What's the one with the big... I don't know. That's good enough. That's a good start.
Brooke Spiegler?
No, Brooke Spiegler. That's a good one. Now I'm thinking of the one with multiple steatosis. No, I can see the picture. So one way we learn these is like picture it in the mind.
Multiple steatocystomas. Pachyonychia congenita?
No. It's the person at the counter who's a cashier checking out somebody.
Oh, God, not this. All right, maybe we get this down so we don't look crazy.
Yeah.